Hi, Dr. David Wong here, and today I want to demonstrate one of the more basic periodontal procedures, the classic free gingival graft. The area that we're treating today are teeth numbers 24 and 25, the lower central incisors. The reason that we're treating this area is because of how thin the keratinized and attached tissue is on the facial of number 24, which has begun the early stages of gingival recession. As we're infiltrating around the facial surfaces of the incisors, you can see how the mucogingival line goes straight through the gingival margin of tooth number 24. You can also note the location of the high midline frenum attachment as well. For the palatal injections, we're using 2% lidocaine with 1 to 50,000 epinephrine to aid in vasoconstriction. And as we're going through this, I just want to point out a few features of the free gingival graft, whose primary purpose is to increase the band of keratinized and attached gingiva, to change the biotype from a very thin, friable piece of tissue to something that is thicker and more resilient. In this situation, this gentleman, who is a 14-year-old healthy male, is going through orthodontic treatment for the upper arch, and as they're getting ready to put brackets on the lower arch, his orthodontist has requested that the tissue be augmented in the area in order to prevent any possible future recession as the teeth are being corrected for crowding. At this point, all I'm doing is simply measuring the mesial distal widths of the lower incisors and transferring that distance over to the right side of the palate. From here, we'll roughly be able to determine how large to make both the donor and recipient sites. The initial incision is carried out with a number 15 blade, which is initiated at about 3 millimeters apical to the free gingival margin, and usually will extend somewhere between the middle of the first molar to the distal of the canine. Obviously, this can be modified depending on how much tissue is required to treat the mucogingival defects in question. Unlike the subepithelial connective tissue graft, which is typically performed for root coverage purposes, the free gingival graft that we're doing today will include both the epithelium as well as the connective tissue layers of the palate. In addition to the differences in how the tissue is harvested, I also want to point out that a free gingival graft's purpose is primarily to increase the band of keratinized and attached gingiva where mucogingival defects are present, whereas a subepithelial connective tissue graft is primarily used to cover recession defects. In fact, root coverage with a free gingival graft is generally considered to be rather unpredictable. Now that the donor site has been roughly outlined, I want to point out that the depth of the incision is roughly about 1.5 millimeters in depth, which equates to about the size of the bevel of a number 15 blade. So what we're doing next is just sharply dissecting out the donor tissue, which once again will include both the epithelium as well as the underlying connective tissue. For teeth numbers 24 and 25, you'll typically need between 9 and 12 millimeters of tissue. As far as the depth is concerned, I generally like to make mine about 9 millimeters in depth. The reason for this is because I typically will harvest the tissue first and prepare the recipient site second. This issue is a small one. The reason I do this is because it allows me to manage one bleeding site at a time. But because the recipient site has not been prepared, I typically will take my donor tissue to about 9 millimeters in depth, which will allow me to treat just about any size mucogingival defect. The mistake you don't want to make here is making your donor site too small. As I'm sharply dissecting the donor tissue away from the palate, one thing I want to point out from an assisting standpoint is I like to have my assistant put the surgical suction tip at the distal edge of the wound. That way all the blood will flow downwards using gravity and out of my line of sight. I also don't worry too much about whether or not the rigi from the palate are incorporated into the graft. That's really not an issue at this point. And also, as far as the thickness of the tissue goes, once again, ideally it should be about 1.5 millimeters in thickness. The most significant anatomical structure that most people worry about is the location of the greater palatine artery. Typically, as long as you stay in the neighborhood of the first molar and up to the canine, no anatomical structures of any significance will be accidentally penetrated. The greater palatine artery typically runs alongside the bone versus superficially towards the tissue. So even if you are in the area of the second molar, for example, typically at 1.5 millimeters in depth, you should be in the safe zone. At this point, all I'm doing is using a typical cotton plier to aid in the separation of the donor tissue from the palate. Once again, this is all done via sharp dissection, and once the tissue has been removed, a moist cotton gauze is placed to help achieve hemostasis. I also provide my patients with an acrylic stent to aid in hemostasis once they get home. At this point, what we're doing here is placing the free gingival graft on a moist gauze and just simply trimming the graft to place to fit properly into the recipient bed. Once again, a 12 millimeter graft is pretty typical for the recipient bed from number 24 to 25. And here you can see the acrylic stent in place for the maxilla. This will help in achieving hemostasis once the patient gets home. At this point, it's time to prepare the recipient bed. Using a brand new number 15 blade, I'll typically make a horizontal incision across the mucogingival line. Obviously, when we get around to tooth number 24, the mucogingival line goes straight through the gingival margin, so that's where the incision will go as well. What I like to do with my incisions here is I like to go all the way to the bone or the root surface. At this point, we're not trying to be too delicate with any type of a partial thickness flap design. The extent of this incision usually extends to a point directly beneath the tip of the papilla. After that, 2 vertical incisions will be dropped and extended into the depth of the vestibule. Care should be taken so that the vertical incisions are not centered upon the mid-surface of the root. Rather, it should be made directly on the bone. With the lower lip retracted, you can actually start to see how strong the frenal pull actually is. At this point, I'll simply freshen up our wound margins to make sure that all of our incisions extend to the bone. And our intent here is to eventually get this very thin, unkeratinized, unattached tissue off of the underlying root surface. And I do this by using a blunt instrument such as in this situation, a periosteal elevator, the Pritchard periosteal elevator, to initiate separation of this loose, thin mucosa from the root surfaces. As I'm doing this, you can see that we're taking this full thickness all the way to the bone, fully exposing the root surfaces. And in this situation, at least for number 24, you can see that a large underlying dehiscence is present. This flap has continued to be reflected past the apical extent of the dehiscence so that the full extent of the defect can be visualized. With the flap now reflected, you can see how prominent the underlying roots are and how thin the overlying bone is. You can also see how a orthodontist would be concerned with the upcoming tooth movement. In cases such as these, during the course of correcting the anterior crowding, the tooth can sometimes be moved literally through the labial plate. My next step here is to switch to a fresh number 15 blade, and we're simply removing that overlying flap of tissue, which is once again very loose, unattached, unkeratinized, overall not very resilient tissue. So once this piece of tissue is removed, we will then transplant the free gingival graft that we took from the palate over this freshly prepared recipient bed. In the next step of this procedure, basically what we're doing is using a number 15 blade to ensure that the recipient bed has been properly prepared. And by that I mean once the free gingival graft is placed, we want to make sure that the graft is stable and immobile, because any movement could cause the graft to fail. At this point, using a number 12 Rhodes back action chisel, we're simply scaling and root planing the root surface to finish up preparation of the recipient bed. All I'm trying to do here is remove any remaining calculus or soft cementum that may be present. As far as etching the root surface, this can be performed with things such as a tetracycline slurry, citric acid, EDTA, among other agents. However, the key point here is to make sure that the root surface is clean. It also does not need to be a concave root surface, just simply needs to be debrided properly. The free gingival graft is now being placed over the recipient bed and checked for accuracy here. All we're looking for is a nice butt joint of the graft to the recipient bed. And the next step here will be to suture the graft in place. And as I just showed you here, we're going to use a 5/0 vicryl suture. The way I like to suture the graft in place is by simply placing 3 interrupted sutures along the coronal aspect of the graft in the areas of the papilla. As I'm suturing here, I want to point out that there are several suturing techniques that are out there that are available for use. I prefer just 3 interrupted sutures. Others may prefer to use some type of an anchoring suture or some type of a periosteal sling type suture as well. All of those are acceptable. I think the key thing here is to make sure that we have close adaptation of the graft to the recipient bed, as well as immobilization. Once the graft is properly immobilized, I will actually pull on the lower lip, frontwards, backwards, side to side, to make sure that the graft is truly immobile. I prefer not to suture the apical extent of the graft. Rather, I will leave that part of the wound open, and it will simply granulate in via secondary intention. I have found that this will properly eliminate the frenum pull that was present earlier. In addition to that benefit, I'll also want to point out that this does not add significantly to the patient's post-operative pain or discomfort. Most people still will report the majority of their discomfort being in the roof of the mouth versus the recipient site. And at this point, as we're placing our final suture, you'll notice the lack of significant bleeding there. Hemostasis is relatively easily achieved with just simple moist gauze and pressure. While I'm putting in this final suture, I want to point out that other alternatives to treating this defect today would be something like a connective tissue graft from the palate, or an acellular dermal graft such as alloderm or perioderm or some similar product as well. The benefit of a free gingival graft, however, is that it gains large amounts of keratinized and attached gingiva, as well as permanently eliminates the frenum pull. The downside is that the color match is often inconsistent with the surrounding tissue compared to the other alternatives. The sutures are ready to be removed at 2 weeks, and by 3 months you can see the massive increases in the keratinized and attached gingiva, as well as the permanent elimination of the frenum attachment. At this point, this concludes our video. I want to thank Dental XP for having me on today, and hope you guys enjoyed it.